webinar series on evidence-based practice. The subspecialty focus for this module will be retina, and the question that we are addressing is foveal threatening geographic atrophy. What can we offer? This is a question that is on our minds most of the days because geographic atrophy is something so common in our practice. So that is why this was selected. And over the coming 1 hour, we will be analyzing many of the practical aspects like whether we should observe, whether we should treat, if we are treating, what should be offered the patient, what is the right combo actually, does anything work at all, or is it just an eye wash? And is there anything new coming up in this area? So all these questions we'll try to address in the coming 1 hour. We'll start with an appraisal of evidence. The study selected is an ad hoc analysis of ERITS, the classic ERITS trials, which was published recently in ophthalmology. And we have our research mentor, Dr. Praveen Nirmalan, with us. He will be walking us through the article and explaining its nuances so that we can decide whether this article is relevant to our practices or not. This will be followed by a discussion from the clinical experts. We are indeed happy and honored to have with us today two luminaries in the field of retina in our state. We have Dr. Mahesh. She is our own president and heading the Vitreoretinal Services at Giridhara Institute, Kochi. And Dr. Manoj Suman, an equally accomplished luminary from our Chaitanya Institute, Trivandrum. So they will be sharing with us their precious insights from years and decades of practice, as well as their comments on how this article may or may not be used by practitioners. So this is a rough outline of what's going to happen in the next 1 hour. Before we go into the scientific program, there is a pleasant duty I'm very much looking forward to. Let me announce the winners of the last month's KGO-based quiz that was live on our website. We have two winners. The winners are selected based on the fastest finger and the most top scores in the quiz. So we have Dr. Raisa from Chaitanya Eye Institute and Dr. Rajiv. They are our quiz winners. So hearty congratulations to both of our quiz winners. Dr. Rajiv Palpu is a professor in the Department of Ophthalmology at Sri Mugambika Institute of Medical Sciences, Tamil Nadu. And Dr. Raisa is a consultant from Chaitanya Eye Institute, Kochi. Hearty congratulations to both of you. Keep quizzing. And the mega winner who is the top scorer of all the quizzes in this series will be awarded and will be appreciated in the upcoming KGO session in the Drishti 2025. So with this short introduction, we can go straight to the scientific program. I invite Dr. Praveen Nirmalan to go ahead with his session.
Okay. So we will start. The article that we are looking at today is oral antioxidants and lutein zeaxanthin supplements slows geographic atrophy progression to the fovea and age-related macular degeneration. The question that the authors try to look at is whether oral micronutrient supplementation slows geographic atrophy progression in age-related macular degeneration. And there are two landmark studies, the AREDS age-related eye disease study and the AREDS 2. So multi-center placebo-controlled RCT of oral micronutrient supplementation with a 2x2 factorial design. There were 392 eyes in the AREDS and 891 eyes in AREDS 2. For a brief introduction, a very brief introduction of what a factorial design is. In clinical trials, a factorial design evaluates multiple treatments simultaneously. So the advantage of a factorial design is that you can evaluate multiple treatments at the same time by varying combinations of those treatments and allowing for efficient assessment of individual and combined effects, as well as potential interactions between the treatments. It's particularly useful when two or more interventions are of interest, allowing for study of multiple questions within a single trial. So you don't have to do multiple trials to look at the effectiveness of interventions one by one. You can put them in a single trial and then you can assess the effectiveness. One advantage is that it can help with reduction of the overall sample size required. A disadvantage is that the trial becomes complex, interpretations also then become complex, and you need a little bit care while you are trying to interpret. The outcomes that the authors looked at were the change in geographic atrophy, the proximity to a central macula over time. That's a proximity-based analysis. And also the change in the square root area of GA over time. That's an area-based analysis. So you're looking at two factors here, two aspects here. One is the proximity to the central macula, and then how is that changing over time? You're also looking at the overall change in the area of the GA over time. Each was measured from color fundus photographs at annual visits and analyzed by mixed model regression according to randomized assignments. We look at the important results. Now, if you looked at the paper, and if you have not looked at the paper, I would advise that you look at the paper. The paper has got multiple tables. It's got a lot of data in it. We'll look at just the important data that's necessary for us to have an interpretation and try to take these results into practice. In the ARIDS, that's the first trial or first study. In the ARIDS, proximity-based progression towards the central macula was significantly slower with randomization to antioxidants versus none. So it showed that the proximity-based progression towards the central macula was slowed down with antioxidants compared to none. And this was significant with a p-value of 0.012. The rate of progression is given at 50.7 millimeters per year versus 72.9 millimeters per year. ARIDS 2 also showed that proximity-based progression towards the central macula was significantly slower, with randomization to lutein zeaxanthin versus none. Now we need to look at a small difference between ARIDS and ARIDS 2. In ARIDS 2, you have the supplementation with lutein zeaxanthin. In ARIDS, you had the supplementation with beta carotene. So in ARIDS 2, you had an arm that had beta carotene. You had an arm that had lutein zeaxanthin. In those who are not given beta carotene earlier, or who are not given beta carotene simultaneously. So there is a slowing down with randomization to lutein zeaxanthin in ARIDS 2 also. That's in the proximity-based analysis. In both ARIDS and ARIDS 2, the area-based progression was not significantly different with randomization to antioxidants versus none. So you're seeing that what the authors have shown in both the trials, in both the studies, is that the area-based progression is not slowed down particularly significantly with antioxidants, whether it's beta carotene, whether it's lutein zeaxanthin. And if you look at the paper, you can also see that there has been zinc added on versus not added on, especially in ARIDS. So you've got multiple combinations here. I'm just keeping myself limited to the two major combinations, that is the addition of beta carotene in ARIDS and lutein zeaxanthin in ARIDS 2. And we're saying that area-based progression was not significantly impacted by the antioxidant. It did not differ significantly between the antioxidant group versus the placebo group. Whereas proximity to the central macula and the progression towards the central macula was significantly slowed down by antioxidants. So just keep that distinction in mind. Which brings us to the point. How do we balance the clinical and statistical significance now? And that's the key to interpreting an evidence-based article. It's not about looking at statistical significance. It's not about saying that there is a statistical significance in isolation. It's about balancing the statistical significance and the clinical significance so that we can carry that onto or into clinical practice. Now, do we consider duration of follow-up? Is the follow-up duration sufficient to detect clinically significant differences? In a condition like GA, late ARMD, this is an important consideration to have. How long must we follow up to be able to say that, well, we are able to make out a clinically significant difference? And that means the rate of progression that normally happens towards the central macula, the rate of progression that happens in the non-central area. And if we want to consider visual acuity as one of the outcome measures, is that a feasible, pragmatic outcome measure to consider, especially if the rate of progression of the condition to the central macula is going to be slow? To put that into perspective, if we say that, well, it does not impact on visual acuity changes, visual acuity has not changed much even with antioxidants compared to placebo, so there's not much point in giving antioxidants. Would that be a fair interpretation, or would that be a, what do you say, a less fair interpretation? So how do we interpret? And what clinical aspects do we consider when we interpret the evidence? If clinically significant changes take time to develop, should we wait for conclusive evidence before we integrate the intervention? Now, that's a question that needs to be looked at, but that's also a question that brings into how long do you wait before we say, well, I'll take the leap and start integrating the evidence, or start integrating the intervention based on the available evidence. Now, if it takes 5 to 10 years for a clinically significant visual acuity change to occur, do we then say, I will not advise or recommend the intervention till that period of time? It again depends, even if you're looking at the area, the speed of progression towards the central macula or the speed of progression in the non-central macula. How long do we wait before we say that, well, I think we should proceed with the intervention at this stage? Even if we are not able to see clinically significant change, there is a statistically significant change, so let's proceed. So how long do we wait? Should we proceed if there is statistical significance, even if we are unable to show or assess clinically significant differences? How do we titrate clinical significance? In terms of mild, moderate, or in terms of what is a quantum of change that we would say is sufficient for us to intervene? That's a consideration that we must look at. And it's a consideration that we must look at before we enter into the interpretation. As a practitioner, the consideration would be, I might be willing to recommend antioxidants if I feel that X percentage of subjects will improve, or if I feel that progression might be reduced or slowed down in X percentage of subjects, or by so much in terms of an area. That what is your level of clinical significance, or what is a consensus level of clinical significance? A clinically significant change is something that must be considered. Those are things that you need to keep in mind. You need to consider the nature of the condition. Is the pace of progression slow? Is it rapid? Is the direction of progression for GA, is it towards the central area? Is it sparing the central area? Is it a donut shaped? Is it a horseshoe shaped condition that is sparing the central macula? Can we say that, well, it's all right if it is progressing, but not towards the central area, as opposed to it's not progressing much in the non-central area, but it's progressing faster towards the central area. So there are small subtle changes there in the direction of progression that we need to consider. Is it a relentless progression? GA is supposed to be relentless. Is it a relentless progression? Is it an intermittent progression in cycles? Is there a potential for reversal of changes that occur? And what are the other factors that can affect progression? You've got environmental factors, you've got personal and behavioral risk factors, you've got genetic factors also that can impact on progression. Which then brings us to a question that is a dilemma for most chronic conditions with slow progression. How do you interpret results? And so you need to take a step back and say, well, do I understand the pathophysiology of the condition? So in this case, we need to understand the pathophysiology of late ARMD. We need to understand the pathophysiology of GA. How does it occur? What causes it? Where does it occur? And how does it progress? And what's the differential progression? At the tissue level, at the cellular level, at the molecular level, at the genetic level. Where does the intervention work best and why? And we look at it from two aspects, structurally and functionally. Is there a differential effectiveness between incident and prevalent conditions? So does the effectiveness of the intervention change if we apply it for an incident GA, a newly diagnosed GA without any prior interventions, as opposed to a prevalent GA, which possibly might be in an older demographic, possibly has had interventions in the past. And that question becomes important, especially when we look at beta carotene and lutein zeaxanthin and the effect of beta carotenes on the absorption of lutein zeaxanthin. In this particular study, they found that there is a difference between incident and prevalent GA. We consider possible structural elements and consequent functional changes. If incident GA is not proximal to the central macula, it may show benefits from supplementation in area-based analysis, but may not show benefit from supplementation in proximity-based analysis. If incident GA is proximal to the central area, it may show benefit in proximity-based analysis, but may not show benefits in area-based analysis. So it's also dependent on the initial location, its proximity to a central area. And we'll see more about this later, but just keep this in mind that the initial location matters and that can alter the effectiveness of the antioxidants supplementation. The location and extent of prevalent cases may also show differential impact, as well as the effect of beta carotene versus lutein zeaxanthin. If you look at pathophysiology, balancing structural and functional elements, which is the area of the macula that's most relatively functionally relevant. How much of the full macular grid is a central ETDRS subfield? And that then brings us to the visual acuity, distortion of vision, and all the effects on the vision. There is the most concentration of antioxidants in the macula. Can that impact on the results after supplementation? And so we then tend to think of, well, then let us split the macular region into a central macula, the paracentral macula, and the peripheral areas. We have those structural differences there, or we have these three structural areas. And then we have the functional differences there. So which is functionally more relevant? Where is the most antioxidant concentration? Is it in the peripheral areas? Is it in the paracentral area? Is it in the central macula? If I give antioxidant supplementation, where is it going to, can I say, end up in the macula? Which part of the macula is it going to be more concentrated in? What is the effect of that? So those are things that we think of as we're looking at the results. So what we had from the paper, the main important results is that there was a change in the proximity-based analysis or the progression towards the central macula, and antioxidants were helping to slow down that progression. In area-based analysis, antioxidants versus placebo didn't seem to have much difference. It did not affect the progression, right? If you look at the paper and if you look at the tables and if you look at the visual acuity changes there, you can see that there was not much of a difference in the visual acuity there. And then if you go deeper down, you can see that in certain areas, the provision of antioxidants helped with the visual acuity in slowing down visual acuity decline. But the visual acuity, the mean duration of follow-up was 3 years, and the visual acuities were mostly in the 2040 region, 2040 to 2050 region. So in terms of decline, you have to consider what exactly would you consider as a clinically significant decline, and how long do you have to wait to say that, well, it actually helps to reduce that decline. The additional factor that you need to consider in our population would be cataracts, would be the effect of cataract surgery on degeneration, as well as other comorbid conditions like diabetes and myopia and other things that can also affect the macula. Let's look at GA in Asia. Is GA an important problem for our population? The pooled prevalence of GA was 1.57 per 1,000 persons. GA was more prevalent in South Asia, based on studies from India and Nepal, about 3.82 per 1,000 persons, compared with East Asia, that included China, Korea, Hong Kong, Taiwan, Japan, and the Singapore Chinese study. This comes from the Asian Eye Epidemiology Group, published in Ophthalmology 2020. Let's now look at antioxidants in South India. Antioxidant supplementation with beta-carotene and vitamin C and D did not affect cataract progression in a population with a high prevalence of cataracts, whose diet is generally deficient in antioxidants. That's published in BGO. It's an older paper, 2005, 2006. So, supplementing with antioxidants, beta-carotene, vitamin C did not have an effect on cataract progression. Now, that the background for this is that there were papers that were saying that antioxidant deficiency had a role to play in cataracts and cataract progression, although the role of beta-carotenes was on both sides. For North India, lower blood antioxidants compared to Western populations. Vitamin C carotenoids were significantly lower, retinol was significantly lower than in European population. This came from the INDI study that was done in the 2005-2006 time. The INDI study had also reported on AMD prevalence in India in the 2010 period and said that late AMD was lower. The rates were nearly similar to, especially for early AMD, was nearly similar to the Caucasian population. They had also looked at the genetic changes with AMD and that identified few changes that were unique to an Asian Indian population. I think that paper came out in 2017 or 18, around that time. So generally, what we have seen is that the Indian population has a lower antioxidant level compared, including vitamin C, carotenoids, E, compared to the Western population. Which then brings us to the question. So if we are going to supplement in a deficient population, what dose of antioxidants must we consider? Should we consider for vitamin and antioxidant repletion? Should we consider for an optimal health status? Should we consider to prevent progression? What are the side effects that we must look at? What are the effects on other systems as well as conditions like cataracts? So quite a bit of things that we need to then look at when we are thinking about supplementing. So it's not just that we have supplements available. There is a condition. The evidence from the Western population AREDS and AREDS 2 shows that supplementation slows down progression. Is the condition similar in the condition of interest, GA or late AMD in this case, similar in our population? Is the antioxidant status similar in our population? When we consider supplementation, what aspect of supplementation or should be considered? Is it sufficient to bring it back to a normal antioxidant state? Do we have to supplement to a higher level so that we can prevent progression? How long do we supplement? What side effects do we look for? Now, side effects are important because the beta carotene started getting a slightly, and if I can say, bad reputation because of several factors. One, that they found that it increases lung cancer rates in those who had a history of smoking over current smokers. Two, they found that beta carotene actually slows down, competes with lutein zeaxanthin in the gastrointestinal absorption and actually slows down absorption of lutein zeaxanthin. And so there's a competition that can happen when we are having multiple antioxidants. There's an impact on other systems that can happen when we are giving antioxidants. So these are things that we need to look at. So we have a paper. We have a good study. AREDS was a good study. AREDS 2 was a good study. A good design, a factorial 2x2 design, looking at multiple arms, an ideal design, an RCT design, duration of follow-up of 3 years, reasonable number of eyes, 392 and about 891 eyes. That shows a particular result. Can we take that into our clinical practice? Things we need to keep in mind is that we don't take it into our clinical practice just because a p-value says that it's less than 0.05. We don't take it into clinical practice just because we feel clinically that it works, while we don't have a supporting evidence to show that it works. Which then means that we really need to be clear about what clinical parameters and the quantification of those clinical parameters that we consider for identifying clinical significance. It's something that we need to think of beforehand. So for GA, what would that be? If it is slowing down progression towards the central macula, what amount of slowing down of progression towards the central macula might I consider as clinically significant and worth giving the interpretation? What are the side effects that can happen and how do I balance that? You want the benefits to override the side effects. So you need to look at both. So essentially it's a balance that needs an understanding of pathophysiology, physiology, anatomy, pathology, and their interactions with the intervention. So I will stop there and hand the discussion over to the clinical panel for further movement on this.
Thank you, Dr. Praveen. I mean, it was a very complicated study design that was made maybe extremely simple for explicitly for the purpose of our members. Thank you so much. So we will now go into the next part of this discussion. I'll be putting some quick questions and the panel may be giving us some crisp answers. So the first thing I want to ask, I'll begin with our president. So Dr. Mahesh, I would like to know whether there is this observation in the study that geographic atrophy is less common in the fovea and that there is a protective effect for it to happen. So more atrophies are seen peripherally and that the rate of progression is also different So what do you think in your practice? Do you find more of geographic atrophies like that only, the distribution?
Uh, Thank you, Dr. Ladika, for inviting me to be part of this session. Uh, in fact, before thinking about geographic atrophy, as such, the Asian and Indian population is mainly pachychoroid. Okay, the choroid thickness is high and not thin choroid like the Caucasian population. So generally, what we see is the pachychoroid spectrum with the pachychoroid pigment epitheliopathy sort of thing. So that standard drusen and geographic atrophy is quite rare. In the study Dr. Praveen showed, it is 1 per 1,000, maybe even less. So I don't, if I see one case in a week also, it is maybe I'm not giving much importance to geographic atrophy. But as such, the geographic atrophy is rare in our population. Number two, for diagnosis of geographic atrophy, clinically, if you have a big atrophic patch in the macula, it is very easy to diagnose. There is no problem. So otherwise, in a drusen with patchy atrophy, you need autofluorescence. That is what I feel. So which is not very possible in our general ophthalmology practice. And so ultimately, based on the study, if we start giving antioxidants to everyone with the pachychoroid pigment epitheliopathy, dry AMD, drusen, everything labeled together as dry AMD by a general ophthalmologist, I think it will be little over treatment, because once you start the treatment, it is like they have to continue, for at least 2 or 3 years, so that we see any loss, means stopping of progression or some difference. Yeah, already documented the GA, fine. Towards the center, I do give.
Okay. So the point is that one has to be sure that you are dealing with the geographic atrophy before starting as arid supplementation.
And your
And
other question, why it is not progressing to the center, I don't know. I don't know. But in both
okay,
the
that
group,
is fine.
the area was, I don't know. Manoj, any hypothesis, I don't know. But the area was increasing in both see, once upon a time, we used to give thermal laser for choroidal neovascular membrane. And always the recurrence will be towards the fovea, that extrafoveal, juxtafoveal, CNVM. If you give thermal laser, the recurrence will be towards the center. Why? I don't know. So these sort of things, I have no answer for that. Manoj can contribute. He is a brilliant fellow.
No, and I think, as you rightly said, Dr. Mahesh, the exact reason why it does not involve the fovea is not very clear, but there are some hypotheses. There are some hypotheses. One of the hypotheses being lutein and zeaxanthin being more specifically located at the center of the fovea. They kind of filter off the blue light, and that is believed to be phototoxic. So that is one thing. And even looking at the density of the cones, and if you look at the relationship of the retinal pigment epithelium to the rods, now in the center, no, it's like each retinal pigment epithelium serves a photoreceptor. Whereas if you go to the little peripheral retina, no, it's like one retinal pigment epithelium serves a group of photoreceptors. So we can imagine that when there is an RPE damage, the photoreceptor loss is little more, extensive in the periphery. So these may be some, and there are some factors which they believe, the cone protective, cone viable factors that are produced by the rods. And there are a lot of these hypotheses. They're all hypotheses, but it's a fact that that the rate of progression towards the fovea, curiously, is less in
Compared.
geographic atrophy, and therefore, no, that also has to be kept in mind when we are talking about a lesion which is non-central, and we look at the propensity of this lesion to go towards the fovea. We should also keep that under consideration. Maybe there's definitely a genetic factor that is involved, and why do some people progress to the fovea and why others don't? There should be a genetic basis also
Yeah.
underlying.
So I
So
think maybe precision medicine may help
yeah,
in the future. So coming to a more practical question, Dr. Manoj, do you treat every geographic atrophy that you diagnose, or do you prefer to observe them? If so, which are the patients you would like to treat straight away, and which are the patients who you would like to observe?
I think Dr. Mahesh has already mentioned one group of pathologies. Like he very clearly explained that pachychoroid is an important feature in our population. So we have pachychoroid atrophy, which is now pachychoroid macular atrophy is now emerging in a concept in the pachychoroid spectrum. So we need to differentiate that because that is not going to behave like the neovascular AMD related geographic atrophy. The pathways are probably going to be different. But maybe there's some common pathway that is also involved there, but then we are not sure yet. So this is one area, no, in the setting of a pachychoroid and atrophy. This is one entity where I think we should not be applying this study recommendations. The other thing
So
is like, yeah, the other area where I would want to wait is smaller geographic atrophy. No, it is an
small,
established fact. Yeah, it's an established.
how small would you like to specify?
No, if you go by the study, that's I have some problems with the study. When I looked at this study, the way they describe GA in ARIDS 1 and ARIDS 2 is slightly different. They
Yes,
used a smaller
1/8
denomination
and 1.
in ARIDS 1 versus a larger denomination in ARIDS 2. So if you look at the literature, it appears as if no, the larger ones have a higher rate of progression as against smaller ones. So it's possible that that cohort, the ARIDS 1 cohort, probably there was some inherent problem there because the average size of the geographic atrophies are probably lesser and probably they were less progressive and therefore the actual role of antioxidants were probably not highlighted. I'm just guessing. So it is possible. So
So,
size is one thing. If there is a small size which is like around 200 and microns or less. That is one thing that I would consider. And
so
also looking at other eye. No, because
okay,
as Dr. Mahesh,
bilateral.
yeah, as Dr. Mahesh said, putting these patients on a chronic drug therapy is not very safe. So therefore, no, we look at other characteristics like can go a little slow or like presence of retinal pseudodrusen, which is an important risk factor for geographic atrophy. So if in Indian population, no, that's probably one of the reasons why in Asia we have less geographic atrophy because the incidence of retinal pseudodrusen is slightly less when compared to European eyes. So if these things are not there, I'll probably go a little slow because as Dr. Praveen brought it out, and again this is a post hoc analysis. This is not a primary analysis. This is an exploratory analysis. So I don't know how much of this thing you can give to this, but having said that, because we do not have anything else to offer, at least in a geographic atrophy which is close to the center. Now we have some evidence that it kind of slows the progression, and therefore definitely in a group of patients, definitely I would advocate this.
Thank you, Dr. Manoj. I would like to add just one point to that. Regarding the size of the lesion, I think the AU guidelines regarding intermediate AMD says, specifies a size that was 350 micron size. So I think Dr. Manoj was also, roughly around 200 to 300, you need not treat. And bigger than that, probably you can treat. But I'm not really sure about the site because would you like to treat something that is nearer the center or away from the center? Because according to this study, something that is away from the center has less chance of progression. There is a slight conflict there regarding the position. I'm not very clear, or whether there is significance at all. Also, I'm not very clear about that. I think what we can say from this question is that if it is a big atrophy and if you're sure it is a geographic atrophy and not any other condition, and if there are other threatening conditions like pseudodrusen, then you really need to treat that patient. Regarding the eccentricity, I think, I mean, any clarity on that? Whether a patch, same size patch near the fovea, one away from the fovea, which would you like to treat?
No, it's a difficult question to answer, but if you look at the rate of progression, I think Dr. Praveen showed in one of his slides, it grows at the rate of so many millimeters square per year. So I think you need to keep that under consideration. So if it is pretty close, then the risk is more of an imminent foveal. So that in that way, and I think one of the areas where we should not probably give, we can probably avoid is central GA. When you already have a central GA sitting there, what are
No.
the role? I mean, what do we?
That we can avoid.
Yeah, that is
we
one
can
area
avoid.
where we can avoid. Yeah.
One more point, Latika. Actually, this is not for general ophthalmology because fundus autofluorescence may not be available everywhere. The edges of the GA can tell you whether there is activity,
Yeah,
that whether it is
exactly.
going to progress. That is one of the more important things. So if you have a paracentral one with edges are very hyper autofluorescent, it can go in. Definitely, I will treat. So in my case of dry AMD, I may do a autofluorescence also to see what is the location and all. And depending on that, this is not
So
possible for a general ophthalmologist, but I am just telling one detail, one clinical. Yeah.
actually, that brings me straight to that question on AF, which I was planning for a bit later, because now you have put that topic. I was just because this is targeting the comprehensive ophthalmologist also. The question is, do you think really that AF should be done in all patients with GA at baseline and before deciding treatment and during every follow-up? Of course, that is the ideal. But what I am asking is, when should a practitioner mandatorily refer a patient for this AF and other multimodal imaging? I mean, of course, it is desirable. There's no question about that. But when is it? Does it become a must refer for the at any time?
Actually, Latika, I think to differentiate dry from wet is more important than quantifying GA. Many cases of so-called dry AMD with GA, there could be a neovascular element and some fluid or something like that, some IR, some intraretinal fluid, not related to RP atrophy. So it is important for general ophthalmologists to recognize those risk factors, recent deterioration of vision or some tinge of hemorrhage, all this stuff, than sending a dry AMD, which is a proven dry AMD, which is having stable vision for an AF. So I recommend general ophthalmologists to rule out wet AMD at any cost by referral rather than evaluating for the dry AMD.
Okay, so that means
Latika, can I just add? My
yes,
take
yes.
Yeah.
on this, my take on this is this: like in every GA at baseline, no, I would like to get an autofluorescence, as Dr. Mahesh said, at baseline. At baseline, try to get an autofluorescence because the surrounding the area of GA, if you have an abnormal autofluorescence, as he rightly mentioned, especially some of the pattern, the banded and diffuse pattern, so the risk of progression is very high. At least you can warn the patient that, okay, that the risk is high, and probably it is this patient know that you put him on an antioxidant because the risk of
Yeah,
progression is high. Number
that's
two,
very
yeah, so that is one area. Number two is like when you have a one-eyed patient. Suppose you have a one-eyed patient, or like you have a patient where there is a lack of correlation between the functional outcomes. Like like Dr. Praveen brought it out, visual acuity is not a very good estimate of geographic atrophy. Looking at readings, reading speed, and other functional assessments are better, but we generally go by vision. And when there is a lack of correlation, it always the FAF helps us to differentiate. I think this is one fallacy with this study where they use clinical
they
fundus
have not
photography.
used
Maybe at that
they have
time,
not
ARIDS,
used it.
yeah, ARIDS, at the time of ARIDS, they were not, it was not part of the protocol. That's why that's the problem with this exploratory analysis. But
But
uh,
one good thing about that is that it is more relevant to the general ophthalmologist who doesn't have access to AF also.
No, it is relevant, but then here where this study, which is harping on proximity to the center, it is difficult for a reader to actually comment on it. Now, if you look
True,
at
true.
the methodology very clearly, they have said that they've not looked at inter-observer variation with respect to progression. There is a problem in this analysis if you look at the methodology. So,
They
I
have
think,
put that AF point in their limitations and just mentioned that they just quoted previous trials which have actually come up with very much agreement between the clinical photographs and the AF, and that was their explanation, which is not really, you know, not enough. Really, AF would have added value to that study. Really,
Can I ask a
that's very
question?
true.
Can I ask a question?
yes,
Yeah.
sir.
Yep. So the basic premise here, I would think that if you want to give antioxidants, is that you are considering that antioxidants are in some way causative for both the AMD as well as the progression. And that's one of the reasons that they say that it's concentrated in the fovea, in the central part of it, and it's protective in that sense. Now, if I take that to our population, which is considered to be deficient in antioxidants, then the intuitive reasoning for me would be that if we are deficient in antioxidants, shouldn't we be having a higher incidence or prevalence of AMD if the carotenoid protective effect is high? We are on the other side. We are having a much lower prevalence as compared to them.
Probably our
Also,
cataracts are also high. The hard cataracts may.
even in cataracts, we saw a reversal.
That probably the
So
reason
the
is the other
protective
one, the tachychoroid. Tachychoroid is protective.
Exactly.
and the
Yeah.
cataracts
So
also. Yes, both.
that brings us to a point that Dr. Mahesh told in the beginning about the tachychoroids. Right, because even in cataracts, we saw a reversal with antioxidants, with vitamin C levels, with the role of beta carotenes. We saw that it was not quite in alignment with what was being proposed in the Western part. So there is a difference there, which again brings us to a point that in a deficient population, when we are saying we want to supplement, our outcome measures are, can we have the same outcome measures and the same outcome levels as they propose, or should it be different?
The other
So
thing,
maybe we will.
other thing, I feel is that from whatever research that is going on in geographic atrophy, the pathogenesis or the mechanism behind geographic atrophy seems to be complement mediated. It does not seem to be heavily relying on oxidative stress. Unlike drusen progression and other saying, geographic atrophy specifically seems to be more complement mediated. And therefore, that's exactly why all the trials, we have the two new agents, addressing complement, inhibitors, and also all other lot of drugs, which are targeting that. And probably that also may be a reason that we are looking at this is just an association, and
Not
probably not,
causative.
we don't have proof as such that oxidative stress maybe it is right. It is multifactorial. Definitely is multifactorial. It may have a role, but it seems that the evidence is strongly in favor of complement
Compliments.
dysregulation.
Yes. So I think that question will take last. So more important is, and this question is to Dr. Manoj. Once you decide upon treating a patient with geographic atrophy, what is your formulation of choice? Especially regarding there is consensus regarding the fact that andoxides, lutein, and zeaxanthin are good for any geographic atrophy. The question is, what about beta carotene? What about zinc? Would you like to go for to avoid beta carotene in most of the patients and go for a low formulation of zinc also? Are they important in your, what do you think?
So it all depends on where I start off. Now, if I have a patient with, are we talking about geographic atrophy as such,
Yeah,
or
only geographic atrophy. We are
geographic?
talking about geographic atrophy in
Okay,
this session.
yeah. So I think in terms of geographic atrophy, as I think I said before, I would treat a non-central geographic atrophy with a combination of lutein and zeaxanthin with antioxidants, because it
Yes.
seems to be additive. From the study, it seems to be additive. I mean, excluding beta carotene, as Dr. Praveen had already mentioned that there's a bioabsorption issue if both of these are combined. So I would look at a preparation where lutein and zeaxanthin along with vitamin C and E is present. Zinc did not seem to have a role according to the
S-
study
I
specifically,
think it
but
was mentioned in one area that a low
low zinc,
concentration of zinc
low zinc.
leads.
Yeah,
Yes, it leads to a
yeah.
slight increase in visual acuity. Actually,
Visual
I don't know,
acuity.
0.09, right, was given as a good p-value also.
No, zinc
So
is, I would definitely, I would also think of zinc because another reason,
mm,
because zinc, in terms of neovascularization, having zinc
yes,
in a preparation always, the risk of neovascularization decreases. That is what, independent studies as well as the ARIDS has shown. So, like, it's no harm in having zinc along, and especially a low zinc formulation. But the bigger question is, we do not have a good combination with these specifics. Having lutein and zeaxanthin in the ratio of 2:1, you need to have it in the ratio 2:1 to have a good bioabsorption. And then having vitamin C adequate levels, vitamin C adequate levels as mentioned in the ARIDS 1 and 2. And then the low concentration zinc. I think this combination, I don't think none of our preparations probably have. We'll have to select the best one amongst this, is what I feel.
okay. So that means the take home is that we can start off with lutein, zeaxanthin, vitamin C, vitamin E as in direts. Go for a beta carotene free formulation, but not a zinc free formulation, maybe a low zinc formulation in almost all patients. We need not, usually we say that beta carotene is not good for smokers or lung CA patients, but I think in general itself, we can go for a beta carotene free formulation. So coming to this, so once you've decided to start, this question is to
On the
Dr.
other hand,
Mahesh.
Dr. Latika, can
Huh.
I just add one point? On the other hand, now if you look at, we are trying to put down beta carotene so much, but in the absence of, no history of smoking or this thing, if you look at the data, it appears as if that beta carotene has had some benefit in, especially in terms of area-wise progression, when compared
That is an
to
incident ARMD, right?
in incident ARMD and also in terms of visual acuity. In the
Mm,
ARIDS 2, they found that the arm that received beta carotene had less progression. So maybe if our history taking is very clear, history taking is very important when we give antioxidants, because we need to find out if it is a lady, probably you would try to avoid zinc, and in terms of anemia, you have to think of that. You think
mm.
of a smoker, you need to avoid beta carotenes. You need to ask liver disease, because too much of these antioxidants over a period of time is going to aggravate liver disease. So you may have to spend a bit of time in asking the right questions before now we put them on antioxidants.
That was extremely relevant and useful point. So we have to take a good history, especially regarding anemia in ladies, anemia in whoever, and especially more prone ladies being more prone, smokers, lung CA, liver disease. So there are so many things, and the next question is to Dr. Mahesh. This is a slight, I don't know the answer to this question at all. I cannot find the answer also. How long do you actually give these supplements to your patients? What is the end point? And if you are giving it for more time, like do you give treatment-free intervals? Are you expecting any sort of toxicities? How do you monitor these patients? What do you tell them?
Uh, Even I don't have a definitive conclusion, but since this basically we are giving antioxidant to improve the antioxidant concentration in the blood, right? So there is no half life like that. So I usually give for either give for 2 3 months and give a break, and then again 2 3 months like that, or some people give alternate day like that. Some people The other option is in a auto, I mean, AF proven GA near the fovea, probably you can give long term with the monitoring. Uh, I don't know. I don't have an answer. Till when, I don't know. Absolutely no idea.
About
I
what
have
about
given
Dr.
some cases I have given continuously if the other is already gone. I have one patient who has a GA just around the fovea, uh, and vision is gradually deteriorating. Visual function is deteriorating. This patient is all the past 5 6 years he is on antioxidants. So there are some patients like that.
Personally, I also I give for 2 months, then break, then again give. That's the way I do. But Dr.
Absolutely.
Manoj,
Yeah. There's
uh,
no scientific evidence for this, but we do
no,
that.
no.
We do that.
Yes, experience. And Dr. Manoj, do you think LFT is necessary for these patients?
No, I do not get in practice. I do not get an LFT done, but I would definitely sound to them saying that that I also would give them like give them after 2 months. I give them a month break. I call them drug holiday. I tell them that I'm giving you a drug holiday because no, I'm not sure whether this will this is bad for your liver. So I think that much information I would pass on to the patient so that but definitely, alcohol consumption or like has an obvious liver disease, I would probably not give them.
So I think Dr. Manoj's from Dr. Manoj's experience, two things would be good to look at before you start treatment for GA. One is an AF at baseline, that is autofluorescence at baseline, as far as the eye is concerned, and second is an LFT. Just a baseline LFT doesn't do anyone any harm, and if it's a very deranged LFT, you have to think twice before starting long-term, supplementation. So. Coming to we don't have too much time. So I think I am just touching upon the latest here. Uh, we have touched upon most of the contemporary things. Dr. Manoj was just mentioning about the complement pathway, and recently we have two drugs approved by the FDA also for intravitreal injections to arrest, and they're supposed to be very efficacious. So, but they're prohibitively expensive. And so, what do you think, Dr. Mahesh? What do you think that means to an economy like ours now? Never ever or sometime.
We will make biosimilars.
That's
We
good.
will make
Yeah,
we
that's
will
a
make
nice.
biosimilars. After 5 years, we are free to make biosimilars, right? So patent,
Okay.
also
So we
Indians
can
will
wait.
make biosimilars. No, as such,
So
this
we
is
can
not a
wait.
fast. See, the CNVM, if you wait for a couple of months, eye is gone because of the scarring. In this case, we don't have that much of a problem suddenly in 2 months or 3 months. So
Mm.
I feel we'll take help from RF study and give antioxidants and then wait for till our biosimilars are in the market.
So I think
Okay.
I think more importantly, we can encourage our patients, as Dr. Praveen had already mentioned, the levels of these antioxidants are less in our population. We encourage these people
Right.
to have a more
Right.
balanced diet, have more fruits or like more these colored vegetables, colored vegetables and fruits in their diet. That's something that we should encourage. Talk about
I think
smoking. Smoking is an important risk factor. We need to talk to them about smoking, tell them to stop smoking because it's an important risk factor for progression of GA. BMI is an important factor, maybe obesity, taking care of obesity, and other comorbidities, diabetes, hypertension, all these plays a role. So especially if there's a family history of somebody with a GA, these are patients who have a very high propensity. So these are patients now who can be enrolled for these trials and these things. So otherwise, I think right now because these drugs are too, it's like it'll come to around 1.5 to 1.75 lakhs per injection, and these are like monthly injection, and they come with their own problems, intraocular inflammation, high risk of secondary neovascularizations. So that even it's I don't think even in the US people are very sure about it,
Okay.
and that's
So
probably why this article came about.
Yeah. And coming to the diet, I think there are studies showing that a Mediterranean diet, they're advocating a Mediterranean diet as the best diet to contain the or slow the progression of ARMD. So if are there any more points to add to the discussion? If not, I'm ready to conclude this. But if anybody would like to add anything more, please do. Please feel free to do it now. So shall I conclude?
Yeah.
So this was an extremely relevant and useful discussion. And to conclude, our question was, phobia threatening geographic atrophy. What do we have to offer? So before this particular webinar, I would have said, and I would have prescribed also just AREDS formulation. But now, post this webinar, I will be more wary about what is the profile of this patient. I would go more into the history, more into his dietary patterns, and look at his anemia, look at his liver status, and look at his smoking habits, lung CA. All this were there earlier, but there was no structure to my protocol. I used to just, give antoxids just like that without much thought to it. But this requires a lot of thought. So first, this history is important. Second, the history, family history, the bilaterality, the size of the geographic atrophic patch, all can determine whether you are actually going to treat that patient and for how long. And the formulation you select, as per this study, it may be good to avoid beta carotene because it interferes with the lutein zeaxanthin absorption. And it might be a good idea to go low on zinc. But again, as Dr. Manoj said, zinc is going to prevent wet ARMD formation. So wet ARMD is more dangerous than dry. So zinc is okay. Low doses of zinc should be given is what I feel. And how long to give? There's no consensus on that, but we can give treatment free holiday. That is how it is being practiced by most of the retina specialists here. And we can counsel the patients that dietary modifications and lifestyle modifications are as important as these drugs. So I think, and autofluorescence is desirable. Even at baseline, it is much desirable. To know which are the patients who need ARED supplementation and for how long. So it helps in risk stratification most of all. So with that, I think we can conclude the discussion. Just one more thing, a quiz comes live on the KSOS website at 8:30 a.m. PM. Please do take the quiz and be the winner this time and keep quizzing and be the mega winner at the end of the series. Thank you so much for being with us. Good night.
Thank you, Dr. Lisa.
Thank you. Thank you, Dr.
Thank you. Thank you.